3 points that I mentioned is what we call the trifecta. In terms of the active treatment options for cancer of the prostate, we are looking at surgery as the gold standard, and the other option would be radiotherapy. The different form of radiotherapy would be either high-dose radiotherapy or seed implant. Now, in terms of the high-dose radiotherapy, this is usually suitable for more aggressive cancers. This is also for patients that have got even T3 disease, and what we are able to do is to deliver high-dose radiotherapy in the prostate with minimizing the side effects to the rectum and also to the bladder. In regards to the seed implants are more suitable for patients that have got low-grade disease, especially Gleason 6, PSA of less than 10, and these patients have to have a smaller size prostate with minimal LUT symptoms. And what I mean by LUT symptoms is low urinary tract symptoms. If patients have no difficulty with voiding, then and a smaller prostate with early diagnosis of cancer of the prostate and PSA of less than 10, these patients are suitable to have seed implant. In regards to the different choices for the cancer of the prostate, it is important to look at patient factors, and often patient factors are then going to determine the treatment that the patient would like to undertake for the cancer of the prostate. If, for example, the patient is very concerned about erectile dysfunction, then maybe for that particular patient the appropriate treatment would be radiotherapy. And the reason for that is radiotherapy does not cause erectile dysfunction straight away. Even though we know that the erectile dysfunction onset usually takes place about 18 months down the track, but it is more insidious and it's much slower in onset compared to surgery. The main reason for the erectile dysfunction from radiotherapy is because the radiotherapy affects the blood supply to the penis, and usually it takes up to about 18 months for the effects of radiotherapy to cause the erectile dysfunction. However, it can be treated with PDE5 inhibitors such as Cialis or Viagra, and the patients are still able to have some erectile function after radiotherapy. One problem that patients need to realize with radiotherapy is that if the patient does choose to have radiotherapy, they would not be a suitable candidate for surgery if the radiotherapy treatment fails. For some men that are very concerned about erectile function, HIFU could be an appealing choice in treatment of the cancer of the prostate. HIFU treatment is a newcomer in the treatment for the cancer of the prostate. Unfortunately, we haven't got the same data that we have for the gold standard, which is surgery, and for radiotherapy. The data at the moment that we have for HIFU is up to about 8 years, and at the moment the statistics is very good. However, we lack the 15-year data that we do with the gold standard treatment. The HIFU treatment is more suitable for patients that are over 70 years of age with intermediate risk of the cancer of the prostate, and those patients that would choose not to have hormonal treatment. The other advantages of HIFU treatment also would be for patients that have failed radiotherapy and there's no other choice in terms of ongoing treatment for the cancer of the prostate other than hormonal treatment, which long term would fail. So HIFU treatment in that situation could be a salvage treatment for those group of patients. Now, in advanced disease of the cancer of the prostate, then the treatment choices there are having chemical castration. And in terms of chemical castration is what we talk about hormonal treatment. Sometimes we can use intermittent androgen blockade, and here what we're doing is in suitable candidates, in suitable patients, is we giving the patients hormonal treatment for a period of about 9 months, and then we once the PSA has reached a nadir, then we stop the hormonal treatment and still monitor the PSA regularly for the patients, and we sometimes are able to leave the patients off treatment for a period of 6 to 9 months, And this is very beneficial for the patients because their well-being is improved. They improve their physical activity. They feel better in themselves, and it allows them to get some of that muscle mass back, and also less likely to cause leaking of the calcium from the bones, which is the osteoporosis. So sometimes we do this for a number of cycles, and certainly the patients feel much better with intermittent androgen blockade. Sometimes we have to do what we call maximum androgen blockade, and that is in patients that the PSA is going up and they are not responding only to the injections, so we have to supplement medication to the injections. And the injections can be either the Eligard, Leukerin or Zoladex. These are the three most common names that that patients would recognize. Now, in terms of the ongoing treatment with patients that have got advanced disease for the cancer of the prostate, the other treatment include also chemotherapy. And the new treatment that has been recently approved in terms of chemotherapy is the Taxotere. And this has been a great advantage for the patients because it's very well tolerated, and patients have certainly got some improvement in quality of life as well as life expectancy during this period of difficult time that they're undergoing treatment.